Okay, next up is another friend, is Kathryn Chatfield. Over time, it's become lonely to be the only cardiologist left alive in RASopathy land until Katie joined. And she's doing amazing work and is going to speak to us about therapeutics using MEK1 for both cardiac and lymphatic indications. Welcome, Katie.
Well, thank you so much for the invitation to come and give you an update about outcomes of MEK treatment, MEK inhibitor treatment for cardiac and lymphatic complications. So this is going to be a lot more clinical, kind of practical, like real world, what's kind of happening in the world of cardiology right now. So I'll start. I have no industry or other conflicts. The images that I use are given with permission of families, and I almost didn't have a pathway picture in my talk, and then I decided I couldn't do that. So it may be a little bit more simplistic compared to Dr. Bennett's, but are kind of just to remind us of the two pathways that can be activated in the RAS MAP kinase pathway. So you can have AKT activation, mTOR, or MEK activation, and we have drugs that target both of these pathways. So I'm mainly going to talk about trametinib and a little bit about mTOR inhibitors, but now there are 4 FDA-approved MEK inhibitors in the United States that have all been approved for cancer indications, but are being, and selumetinib is being used for NF1, but otherwise we are doing this all off-label. So just to kind of, what I'm going to talk about really quickly is here, I'm going to talk about the review of the literature, what's been published to date about treatment of patients with MEK inhibitors, and then talk about the outcomes or kind of like our conclusions about what this is doing for patients, talk about side effects and adverse events, standardization of treatment protocols and how we're doing that in mainly in the United States. Make brief mention of, still thinking about using mTOR for Noonan syndrome with multiple lentigines, and then talk a little bit about how presently and moving forward, we're going to accomplish data collection and really kind of real world collection of outcomes in this space. And then talk a little bit about like what the future holds. But I think Dr. Bennett has already covered some of that future, and Dr. Gelb will talk about that more tomorrow, so that will be brief. So where we started with this, Dr. Andelfinger and Gregor and others first reported 2 patients with RIT1 in 2019. And then this just like started a firestorm, to be honest, in the world of clinical cardiology, I think both in the US and in Europe, that now has led to a larger paper that was recently published by Cordula Wolf and Dr. Gelb and Dr. Andelfinger and many others that took a collection of 30 patients and looked at those outcomes and with a comparison group, which was just published this year. So what is sort of the cumulative data that we have that's published so far? And I might have missed actually one paper that has a couple lymphatic cases, but up to date, as of last week, there are a total of 48 unique patients that have been treated with MEK inhibitors. There's some follow-up on 5 of those patients, so that have been reported in more than one paper. And so we know kind of a little bit of longitudinal information if you can extract that. There's a cumulative 45 months of treatment time for some patients, and some patients have been treated for 3 years or longer. We do know that recurrence of some of both cardiac and lymphatic complications can occur. But as I've said, since much of this literature has been published, this drug is being used widely in the cardiology community, and likely there are possibly hundreds of patients that actually have or are being actively treated primarily for hypertrophic cardiomyopathy and lymphatic complications. So if you look at just the case reports over time, there's been an explosion, but this is mostly the one recent paper. There are a number of other indications that I'll talk about as well. So not only are we treating as primary indications hypertrophic cardiomyopathy and lymphatic dysplasia or chylous effusions, but arrhythmia has been a primary indication for treatment, and epilepsy has been as well in one case report. So when you kind of look at the genes or the summary of all the genotypes that have been treated in hypertrophic cardiomyopathy, you can just see the numbers here. So RAF1 has been the most prevalent group of patients treated with MEK inhibitor for hypertrophic cardiomyopathy, followed by RIT1, the original cases that were reported, a number of patients with Costello syndrome, including ones that we published with Dr. Weaver and myself and Dr. Geddes in Indiana. PTPN11 is a much smaller proportion. BRAF and LZTR1. And then as far as lymphatic treatment, this is a smaller total number of patients, but RIT1, PTPN11, SOS1, and RAF1 are the genotypes that have been treated. There's a handful of patients that have been treated for both problems simultaneously, and those were RAF1, PTPN11, and RIT1, one RIT1 patient. So that's sort of the landscape of the patients that are being treated. So the indications, I've kind of stated this, but hypertrophic cardiomyopathy, primarily in critically ill infants who are hospitalized, was the was the primary patient population for which the drug is being used and is easier to justify as an off-label drug. Those patients generally have heart failure symptoms, and sometimes they have associated comorbidities, which may additionally drive motivation for using it. Those patients may have also had refractory chylous effusions, or they may have only had refractory chylous effusions. That may be the isolated primary indication. Arrhythmias have been a reason for treatment, refractory seizures, as I mentioned, but also malignancy, and then combinations of all of these. So a really important thing to think about is, what is your outcome measure? If you're going to treat a patient, what are you going to measure to determine if you have improvement? And it may seem simple, but it's really not always as simple as it might seem. And it's really important for clinical trial readiness to know exactly what the most important primary endpoints will be. Hypertrophic cardiomyopathy, like, one thing you can do is assessments of heart failure, and that's scored, but that can be a little bit more difficult to do in infants and somewhat subjective. There are other measures, though, that have been really helpful, and one that's especially helpful early in treatment that may be the first clue that you're seeing some effect is the NT-proBNP. But also we look at echocardiogram parameters. So this is just an example from our group of patients treated with Costello syndrome that shows, if you look in an individual patient, you get a lot of variability in echo parameters, but you can see trends in decrease in size of the interventricular septum. But NT-proBNP tends to be a better marker in some cases, where you can see over time you can have abnormal starting values that normalize over time. Outcome measures for lymphatic disease is really much more hard, because what exactly are you going to measure? There are ways that you can determine, what is going on, like doing MR lymphangiograms and special imaging that's done in the catheterization lab. This has been done a lot at CHOP, and Dr. Yovdori's been a pioneer in doing a lot of lymphatic intervention and getting pretty pictures for us. But MR lymphangiogram is a really useful technique to identify chylous or lymphatic dysplasia, but it's technically difficult, and it's only available in some very specialized centers that have the expertise to do it. If you're trying to measure improvement in chylous output, clearly you can measure, like, the output from a chest tube. Once the chest tube is removed, then you may have to measure time to extubation, or time to weaning from positive pressure ventilation and weaning off of oxygen. So those are other measures that can be used. Another presentation of lymphatic dysplasia can be protein-losing enteropathy, when chyle is essentially leaking into the gut, and patients can present with like edema and low albumin. And some patients with these presentations have been treated with MEK inhibitor, and you can actually just measure in patients with chylous effusions or PLE a serum albumin level that is very low when they have uncontrolled disease, and with treatment with MEK inhibitor, that normalizes over time. Other outcomes can be measured for other presentations. So the paper that reported on seizure treatment showed normalization of EEG. And then if you have a JMML phenotype, we know that it doesn't always need to be treated, but if it's coincident with another problem, it's easy to measure a white blood cell count and show that in one of the patients that we treated had a JMML in addition to hypertrophic cardiomyopathy and lymphatic dysplasia. That was in our a lymphatic paper published with Taizo Nakano at my center. We could see that the white blood cell count came down with treatment. So outcomes, basically kind of without going into a lot of details, which you can read in Dr. Wolf's new paper, suffice it to say that trametinib significantly reduces death, transplant, and cardiac surgery risk. It showed no serious adverse events. Frequent side effects include cutaneous and mucus irritation. I can talk a little bit more about that. In the larger cohort of patients, death did occur in 4 of the treated patients, which was 13%, which was better than in the control group that had about a 30% mortality rate. Other deaths have occurred in other case reports, but overall we need to study these larger populations to really know which patients are high risk for a poor outcome and which patients are the best candidates based on genotype and other medical features. So what are the side effects that we see with treatment with trametinib? By far the most common is the skin toxicity. So patients can get what starts as an eczema, it can evolve into a folliculitis, stomatitis, and can turn into a cellulitis. In newborns, sorry, I got ahead of myself. You can see sometimes elevated transaminases. Necrotizing enterocolitis has been seen in some very young newborns. It's unclear if that's caused by the MEK inhibitor because these are generally preterm, very sick babies in the NICU, but it's still something that we have to pay attention to and affects our treatment. And some off-target effects, which we wouldn't really say are side effects, but interesting findings. We've noticed hair changes, growth changes. So this is one of the patients we published. So starting MEK inhibitor, she had acceleration of growth. She stopped MEK inhibitor and her growth trajectory kind of dropped off. And then she had recurrence of chylous was restarted and her growth improved again. In patients with Costello syndrome, we've seen that when they've had papilloma resected, their papilloma tend not to grow back when they're on MEK inhibitor. So how are we going to collect this data? In the United States, there's an organization called Action Network, or Advancing Cardiac Therapies and Improving Outcomes Network. This is a collaborative of 52 centers that submit data to do a variety of projects that are important for quality improvement initiatives, data just collection, education, coordinating clinical trials, a lot of device protocols, like for ventricular assist devices. But we recently had an accepted a project to look at HCM and outcomes of MEK inhibitors using the Action Network for data collection. And we've decided to call it, we think it might be called RAS Action because that sounds like it's a good way to add to the title. So what is one thing that we've done as a preliminary step before data collection is a bunch of individuals who have interest in this project and in treating patients with MEK inhibitor put together a treatment protocol, or what we call a harmonization protocol, to help other providers know how to use the medication and what types of things to be monitoring over time. So you don't need to memorize this because we will share it with anyone, but it's the point of this is that we want to help make sure everybody is doing things in a uniform way, that they know what labs and studies need to be monitored and at what intervals, what other exams might be necessary, like potentially looking at the eyes, although we haven't seen any eye problems yet. It was something that we were worried about in the beginning. And then this surveillance and these lab tests become less frequent over time and as the patients are stable. As far as lymphatic specific, that's a little harder. You can do serial lymphangiograms, but again, that's invasive, expensive, and requires the particular expertise. But it also provides, this protocol also has dosing strategies for escalation. We have a kind of additional tables that help with how to address toxicities and how to modify dose based on that. And then we have a skincare protocol. Given how common the skin manifestations are, we have adopted actually an NYU protocol that's used in cancer patients to help prevent the skin toxicities that, if it's used preemptively, is very effective. So how do we know that there are so many patients that are out there? Myself and Dr. Chatfield, who are the co-chairs of the RAS Action Committee in Action, get contact, and Dr. Gelb as well. Probably amongst all of us, we get contacted about once a week to share a protocol and Dr. Andelfinger, he gets them as well. So as a group, we're being consulted very frequently and providing advice to other places around the world about how to use this medication. We distribute our protocols so that we can, ensure to the best of our ability that people are doing things in a uniform and safe way. And so that we'll be able to go back and collect data retrospectively that's uniform among these centers. All I'll say there's still a big question about whether mTOR might be useful. This is a patient with multiple Antigenes Noonan syndrome who had an NT-proBNP that normalized on sirolimus. This is her echo at baseline, which there's a massive tumor-like septum that has resolved after a year or two of treatment. So there's still a question about which drug is going to be best for which patient and based on what genotype, and that's like a huge area. Given that there's other inhibitors and pathway inhibitors, it's going to take us time to sort out which medication is going to be the best for which patient. But we're very fortunate now to be in a situation where we actually have a treatment to offer these patients. So RAS Action is going to do a retrospective study of patients that were treated sort of before the MEK era. So we have a better baseline of what the outcomes were before this treatment paradigm change. We're going to do real-time data collection currently to try and collect what's been going on for the last 5 years and know what the outcomes are for those patients, and then have opportunities to do more prospective studies, looking at comorbidities, the length of treatment, how long we have to treat these patients, should they be treated forever, what are the side effects, what are the off-target benefits, many of those things. Outcomes of lymphatic disease, that's going to be harder to collect that information, but a transplant fellow trained in genetics and cardiology at Stanford, Brendan Floyd, is working on collecting that data. We know that patients who've had lymphatic dysplasia and been treated with MEK inhibitor effectively can get much better. This was also one of our patients that was previously published, but then it can recur, and it's in a different place and a slightly different manifestation. So these patients are going to be at risk for some of these problems moving as they age. We're also trying to get funding to do broader data collection, and I will kind of stop here to be able to answer more questions. But I would just say that we are hoping to get funding to do more of this work and collect more data so that we can get some drugs that are actually FDA approved. But we can't rely fully on federal funding anymore and have to look for alternative sources from industry partners and patient advocacy groups. So we really rely on our partners and people that are involved with a RASopathy network to ensure that that happens. There's other low-hanging fruit that we can kind of look for new data. So there's cardiac databases that collect lots of information about cardiac outcomes, including patient genetic diagnoses. So that's another way that we want to try and get more outcomes data about infants and young children in cardiac units with RASopathies. So we hope that we can do better. I'm going to stop there and hopefully answer some questions, and thanks all the people that have been involved in this work, real-time collection.
So that here first.
Thank you, Katie. So I'm thinking about your slide showing the different genes associated with HCM being treated. And I'm also thinking about Dr. Lee's presentation about how different gene variants have cell type specific effects in the brain. And I'm wondering if there's anything similar going on in the heart. In other words, is HCM kind of the same thing across these different genes? Or do we have any data, and this may be very premature and you need to do the RAS action to figure it out, but to say whether there might be a slightly different presentation across different genes or any different response to therapy?
That's a really good question. It's hard to know how to answer it. The phenotypes are very similar if you look at, on a microscopic level, whether if you look at a biochemical level, if they're really similar, that's hard to know. But we do have a large heart transplant tissue bank at our place. So if people are interested and want collaborating and looking at, biochemistry from explants, I would be happy to explore that. But it does seem that there are different responses based on genotype. So that may be informative, but we have to collect a lot more patients to really understand that.
Yes, thank you for your presentation. So my question is related with the MEK inhibitor. Because as you mentioned, there's this dermatological side effects and also some other side effects. And it's not only in the trametinib. So my question is are those side effects associated with the target, or associated with the mode of action of the specific drug? Or what would you think is the best mode of action of the MEK inhibitor that we can solve those side effect problem?
It's a good question. We haven't used the other MEK inhibitors enough in these patients to know, I think to know if it is a effect of the drug specifically, or if it's, a target, it's what we would expect to happen. It's hard to know. Yes, please help.
Okay. First of all, the skin effects are a drug class effect. It's not specific to trametinib, and I wouldn't have known this had I not shared a cab with Pao on the way here. But it's an on-target, not off-target effect of. So it's from inhibiting MEK itself. So it's doing what it should be doing. Sorry, you're from Novartis. You can add something, please. Do we have a? Do you have the mic to give her? Go ahead.
So what we see in melanoma is that a combination with RAF inhibitors, they are helping with the side effects. But in melanoma, you have a BRAF mutation. So I think for any other where you have BRAF wild type, you would need to have a paradox breaker RAF inhibitor, so the next generation RAF inhibitors as a
Great,
combination
thanks.
part.
Yeah, and we obviously aren't using combo therapy. Thank you very much, Katie. Thanks. Give her a hand. All right, we're going to keep moving along.